Assalamu alaikum. Good evening. Welcome to today's IPD Cathlab Manual Series 16. Already we finished CTU Cathlab Manual Series. You already on the 14th, you talk about the Integrate PCI by Dr. Arun Sundaram, then Professor Saidul Rahman. After that, Cathlab Manual Series 15, the Integrate PCI, same Dr. Arun Sundaram, and also Dr. Kaisar Nasrullah. Today's excellent session. I think we are some discussion about the integrate and integrate PCI. Dr. Khondoker Asaduzzaman, he was very much popular in Bangladesh. My friend and colleagues. He is the senior consultant of Asgor Hospital. And another interesting speaker today, presenter today, Dr. Misbaul Ferdous. You know, he's our fellow colleagues. He's doing very well in China, Beijing, doing more than 5 years working there in Fuwai Hospital, Beijing, China. Also, he's the Vice President of Asian Cardiac Society. Welcome, Dr. Misbaul Ferdous. We are waiting how the China deal with that to get PCI. There are lots of faculties here. I really get full all the faculties here. Professor Amal Kumar Chowdhury, Professor Walul Islam, Professor Sams Manwar, Dr. Abdul Jamil, Professor Khaled and Professor Jilu Rahman. Lots of faculties. Welcome to this session. And now we're requesting Professor Abdul sir, please opening remarks and please start our session. Professor Wadud sir. Professor Abdul sir.
Good evening, everybody, and assalamu alaikum. Today again, we are meeting again on interventional cardiology sessions, CTO sessions. So we'll be hearing interesting cases and the perspectives, how they deal with it from two young entrepreneurs and interventional cardiologists. Why I'm saying entrepreneurs? Because these two are not only doing things, they are also thinking for others and trying to improve others' performance. That's, in a sense, is a case of academic entrepreneurship. And that I really like. Ladies and gentlemen, let us present from IPDI in front of you, Khondoker Asaduzzaman and Misbaul Ferdous. We'll find out how brilliant and how good they are as interventional cardiologist, also as academician. Thank you, everybody.
Thank you, sir. I'm requesting Dr. Khondoker Asaduzzaman. Please start your talk and how deal with the integrate PCI. Dr. Khondoker Asaduzzaman, do you hear me?
Yes, I can hear you very clearly.
Yeah, thank you, Khondoker Asaduzzaman.
Can you show me the slide? Can you show? Can you see my slide?
Yeah, we are seeing.
Yes, sir.
Okay.
Okay.
Assalamu alaikum and very good evening. Respected Chairperson of today's session, Professor Abdul Chowdhury sir, and Secretary General of IPDI, Dr. Mohsin Ahmed, respected teachers, faculties from home and abroad, dear participant, Assalamu alaikum. I am Dr. Khondoker Asaduzzaman, consultant Asgor Hospital. I welcome you all to my today's presentation. Today my topic is successful PCI of coronary CTO, integrate approach. Chronic total occlusion defined as complete arterial occlusion, TIMI flow 0 or somewhere it may be TIMI flow 1 of at least 3 months duration. The incidence of CTO is 10 to 20% of all individuals who undergo diagnostic cardiac catheterization. Successful recanalization of CTOs may be achieved in and around 80% of populations. What should we look for CTO? Clear understanding of the location and type of proximal cap using angiography or intravascular ultrasonography. Pay attention on distal cap, proximal and distal segments, lesion length and morphology. Address side branch at proximal and distal segments as well as calcification. Suitability of the collateral channels for retrograde techniques, which will be talked by our second speaker. And what should I know for CTO? We must know the route of entry, radial, femoral, bi-radial, radiofemoral, antegrade or retrograde, and selection of appropriate guiding catheter, guider selection, shaping and manipulation, appropriate selection and use of balloons, microcatheters and other devices, use of accessories to prevent and tackle any complications. Let us see the first case, my CTO case 1, a 42 years old diabetic, older my inferior gentleman having exertional shortness of breath and history of recurrent attacks of chest pain, which was CCS class 2 or 3 for 6 to 7 months with optimum medical management. His ECG showed key waves in inferior leads and echo showed inferior MI with fair LV systolic function. ECG, which was done outside our country, and it was showed that 95% occlusion at early and total occlusion at late part of mid RCA, having good sized distal vessels filled by collateral contralaterals. And you can see here the angiography on the right side. And on the left side, you can see there is a huge collaterals from the left systems. And on the left side, the right coronary is totally occluded from the left part of mid segment. And with this complaints, patients came to our hospital for further evaluation and management. Then we planned for Cto Pci for RCA. And initially we select the guide catheter and plus left 106 French for the right coronary cannulation and use 3.5 French guiding catheter for the contralateral injection. Initially, I was tried to open up the lesions by using the floppy wire with the help of 1.5 guiding balloon, but I failed to cross the lesions. Next, I used the microcatheter, and with the help of microcatheter, I exchanged the hardware filter XTA, and with the help of microcatheter, filter XTA crossed the lesion successfully. And you can see here on the right side, it's crossed the lesions and entered into the lower branch of the PLB. And after entering into the PLB lower branch, I just keeping the microcatheter in situ, I removed the hardware and extend the hardware by floppy wire, run through floppy wire on the right side, and checked by contralateral injection to see the proper or actual locations of the wire, whether it is in the true lumen or in the false lumen. And after observing the angiographic finding, I go for the sequential balloon dilatations, starting from 1.25 to 1.5, then 2 balloon, and with a pressure of 12 to 14 atmosphere. And after balloon dilatations, you can see on the left side, the vessels is not so clearly visualized due to the chronic low flow spasm. Then I gave the intracoronary nitroglycerin. And after intracoronary nitroglycerins on the right side, you can see the vessels is clearly visualized with some micro dissections at the terminal part of the mid segments of the RCA. So we plan for stenting of this occluded segment that is opened up by sequential ballooning, and a stent was selected 2.75 38 millimeter DSA which was positioned on the left side, you can see here, and deployed at 16 atm. And after deployment of the stent, you can see the angiographic scene on the left side. And after deployment of the stent, the post-dilatation was done with use of 3 into 12 millimeter balloon and a pressure of 14 to 20 atm, and deployment of the stent was seen on the left and right side both. And after the successful post-dilatations and PCI, you can see here the picture on the left and right sides, and you can appreciate the outcome of these CTO lesions. So what is the learning points from this case 1? Actually, the antegrade wire escalation is of paramount importance for successful CTO lesion crossing. The Cto Pci success can be enhanced by concomitant use of microcatheter. Here I used the fine cross, which can provide support to the guide wire. It also allows the guide wire to be exchanged for an atraumatic guide wire after crossing the CTO lesion. Now my second case, a 50-year-old non-diabetic hypertensive gentleman having history of chest pain and shortness of breath for 7 months. ECG showed poor progressions of R wave from V1 to V4, and echo showed hypokinetic anteroseptal segments having left ventricular ejection fractions around 45%, and ECG and coronary angiogram showed the total occlusions at LED ostium, and distal LED was filled by contralateral collaterals, RC having 70% lesion and its proximal segment, and it was treated in stress PCI. First, I attempt for the LED CTO lesions, and you can see here the LED is totally occluded at its ostium, and on the right side you can see the collaterals from the right coronary artery up to the distal to mid part of the LED. So I try to cross the lesions by keeping a wire in the ramus intermedius to give maximum support of the wire of the guide catheter, and then I took a second wire, and it was an intermediate wire, and it's a hydrophilic coated intermediate wire, and I try to negotiate the wire through the CTO lesions, and then at the same time I cross check from the left side, right side to see whether the wire in the true lumen or in the false lumen, and of course we should take at least 2 orthogonal views to see the optimum outcome of this wiring. And you can see the wire cross the lesions very nicely and enters into the mid to the distal part of the LED. And after crossing the lesions, the lesion was pre-dilated with 2 into 12 millimeter balloon, and intracoronary G10 was injected to see the coronary trees as well as to see the landing zone of the LED. But actually I failed to see the landing zone due to the chronic low flow spasms of the LED territories. So I planned for stenting the proximal part of the LED, and I took 3 into 33 millimeter stent DSE and positioned and deployed the stent at 16 atm. And after the initial placement of first stent, you can see here the distal landing zone is very clear, and there is a short segment was uncovered. And then I took the second stent, and overlapping the proximal stent, I deployed the position the second stent, and it was 2.5 into 12 millimeter. And after deployment of the stent, post-dilatation was done, and final angiographic view, you can see here the clear visualizations of the total LED territory, and it was outcome is quite good. So what are the learnings from this case 2? Wire sliding technique is an effective wiring technique to success PCI in CTO. Contralateral injections during CTO PCI allows visualization of the guide wire position and minimize the risk of dissection as well as perforations. Initial deployment of proximal stent may help to visualize the distal landing zone for second stent. And my third case, a 63 years old diabetic hypertensive pleasant woman having exertional chest pain for 5 to 6 months with optimum medical management. Her ECG showed there is a Q wave in inferior leads, and hypokinetic echo showed the hypokinetic posterior segment having good left ventricular ejection fraction. Angiographic showed the 95% occlusions at early and total occlusions at late part of the mid RCA. Left system is quite okay. You can see here the angiographic view, and the PD-PLV was faintly filled from the contralateral collaterals, and RCA was totally occluded from the late distal mid part of the RCA, and the mid part, initial part was 95% lesions. So I took the wire. Initially, I took the wire with the help of a balloon, but it easily goes to the false channel that is in the side branch. So I kept the wire in the side branch and took another wire, and with the help of a balloon, I tried to cross the lesions, but again failed to cross the lesion. And then I took microcatheter and took the hardware Miracle 3, and with the help of Miracle 3, by using the drilling technique, I easily smoothly crossed the lesions. And you can see here, after crossing the lesions, the floppy wire were exchanged with the help of microcatheter. Due to shortage of time, I skipped some of the slides. And after wiring, the predilatations was done by using the sequential predilatations from 1.5 to 2 millimeter balloon, and then I used the 2.5 millimeter and 10 millimeter balloon for optimum predilatations of the lesions and optimum preparations of the vascular bed for easy entrance of the stent. But after preparations of the vascular bed, I tried to cross the lesions with the stent, but you can see here, I failed to cross the stent because most of, I think main reason is here is the backup support of the catheter, I think. So I try to wiring the vessels by a second wire to make more comfort, more support of the catheter. And again, I tried to cross the lesions with the stent, but failed. So what should be the next step? Should I consider the removal of wire and catheter, and should consider the second supportive catheter? Or should I consider the another supportive catheter, that is mother and child catheter? Or should I consider the strip wire? Or should I consider the balloon supported the anchor technique? There is so many options are here, but I took the Guidezilla, and after using the Guidezilla, I tried to negotiate the stents, but again failed to cross the lesions. I stuck at the mid part of the RCA, and you can see here the guide catheter with Guidezilla came out from the right coronary arteries. And then I took a balloon, 2.5 millimeter balloon, within the Guidezilla and inflated it. And with the help of balloon, I pushed the Guidezilla for the deep throttling of the Guidezilla into the mid part of the right coronary artery. And after deep throttling of the Guidezilla, I easily crossed the lesion with this, and the stent was easily crossed. And after crossing the stent, I removed the Guidezilla and then deployed the stents nicely. And after deployments, this outcome is, I think, good. And what are the learnings from the case 3? Actually, the stepwise approach, starting with polymer coated floppy wires and progressing gradually to stiffer wires for safe crossing of the microchannels. Without backup support of guide catheter, Cto Pci may invite the nightmares in Cathlab, like third case. Guide to guide extension catheter may turn an unsuccessful PCI into a successful PCI by creating a smooth pathway for stent delivery across the lesion. So in conclusion, selection of appropriate guide wire, guide catheter are very important for successful CTO procedure. Microcatheter and guide extension catheter are essential tools for assistance of wire crossing and stent deliberation in selective patients. In two-stent strategy, initial deployment of proximal stent may help to visualize the distal landing zone. For the second stent, sidebands wiring at proximal cap can prevent the easy slippage of wire into the false track. Bi-radial approach for CTO is feasible, safe, effective, and promising. Thank you all. Thank you for patient sharing.
Thank you, Dr. Asad. I think you showed the excellent case. I think tutorial-based discussion for the fellows, because you just present how a fellow use the support catheter. It's most important. Catheter should be nicely supported to for engagement, and also use the microcatheter, and changing the wire from the hard to in software, and also use the Godzilla in complex cases. Thank you, Dr. Asad. Dr. Wadud, sir, Dr. Abdul, sir, please comment, sir.
Look at the first case. The first thing you have to notice that he was using M+ catheter for RCA total occlusion, and if the uptake of the RCA origin is not satisfactory, you better choose a proper guide cath to have proper support. Otherwise, you would not have been able to cross the lesion. Look at the first case. He also uses balloon support and only floppy wire, common usual wire that we use, and cross that. That's important. Sometimes you'll be able to do it with a balloon support, but in a CTO case, sure it's a CTO, is more than 3 months old, or a patient without MI, but having CTO, that means a very chronic occlusion. In those cases, using the proper guide wire, he has used Miracle, he has used Filter XT. These are important things. And if you want to be a CTO operator, you have to have the right tools. We have used the microcatheter, which is very important, and also used the binary visualization to see the retrograde feeling and whether you are approaching it the right way. He has used different types of hardwares, hard CTO wires, and also he has used the microcatheter and Godzilla. Particularly Godzilla in certain cases, when you feel difficulty in the stent, is really, really helpful. Thank you for nice presentation of different aspects.
Thank you, sir.
Thank you, Dr. Professor Amal Kumar Chowdhury, do you hear me?
Yes. I think very excellent case. It's a very excellent, and it's very important for the fellows how to do integrate approach with contralateral dye. Asad nicely shown how to help the wiring. So by giving the contralateral dye in orthogonal view, whether we are wiring in the good way or it's the subintimal or like any branch approach of like this. And also, Wadud already said that how to use a Godzilla. This is the two new things little practicing by the budding cardiologist, but interventional cardiologist. But a lot of things for discussion is there. I think there is no scope. This is, I think it is another presentation is there. In second case, I like to ask the Asad, there is a small stent to stent. So due to distal landing zone, there is, I think there is also have some myocardial disease also there at the you showed meticulously, you show that there is a change of diastolic and systolic filling at the level of stent. I don't know. So if we tied with a little long balloon and give a repeated nitrate or verapamil, I think we can find out the distal landing zone so that we can avoid another stent for the economic purpose. Well, because you need you use only very small stent at the end of the 33 stent. So 38, I think it is be okay. It is my small opinion, but there is lot of discussion point is left. Why we did not use the IVAS, why we did not use the imaging MPI viability test, why we did not do the pre and post IVAS. There is a lot of discussion. I don't like to discuss detail. Keep it simple as our economic status. Thank you, Asad. Thank you.
Thank you, sir. You rightly mentioned that there is a microcardial breach just after deployment of the stent. So before the deployment of the stent, it's very difficult to say, assess whether there is microcardial breach or not in situation, sir. This is an important issue.
Okay, I understand.
Thank you, sir.
Professor Saidur Rahman, sir. Professor Saidur Rahman. Professor Saidur Rahman Khan.
Yeah.
Yes.
The three cases Asad has shown from a different perspective. That's good. That your choice is good to choose the cases in a different way. I think for the fellows it would be much better if you make a freeze or a static view of the proximal cap of the CTO to understand that which way you will go, because that one is very important to see the proximal cap, whether it is blunt or whether it is a tapering end. So these are the things, then the fellows can understand that, yeah, this is possible, this may be possible, or these wares can be done, because this is one of the most important the mainstay to treat a CTO or how to start a CTO with which wear and how, because like in first case you have started with a simple wear, but then you have changed it to a low penetration force hydrophilic wear. So that one is that if there is a stump, and if the stump is tapered, or you can see that the segment is not that much long by the dual injection, then you can choose simpler wear. And the second thing is that I usually like, rather than taking a Amplat's catheter for RCA, because for the fellows it is very much important to handle that catheter, because otherwise you'll have to end up with another stent proximally in the ostium. So Ikari right is also another choice to get a good support. And for your second case, what I can tell, because there is there is a tapering end in the near ostial LAD. So the wearing was possible, but it's a long segment CTO. So to understand the microcardial bridging is really impossible. So that's true that what you have nothing to do there. And for your third case, where you have taken the miracle wear after just changing these things, miracle is a wear I use least until and unless. Almost never. I usually like the Kaisar to take rather than the miracles nowadays. And that RCA CTO, the third case, was not that much calcific, but I think that the delivery of the stent, which was very much hard for you, it was because of the angulation of the mid RCA rather than the calcification that much. So at least angiographically, as there was no IVUS there. So in that case, the what you have done, that keeping a balloon there dilated and push the guide extension, this is a very beautiful technique. And usually sometimes Antonio Colombo use it and take not the guide extension, even the guide catheter itself to take up to the distal RCA. He can take that one. So that's a good technique. technique also. Thank you, Asad.
Thank you, sir. Thank you very much.
Thank you. Thank you. Dr. Sams Manwar. Dr. Sams Manwar.
Thank you. Thank you, Dr. Asad. Thank you. Thank you very much. Very good academic cases, teaching cases you have shown, all from all views. Actually, my points have been already discussed by all previous faculty. So nothing much to say. But I must say one thing about the CTOs, the selection of guide. You see, the selection of guide, the first case, you've done quite easily because of the very good guide support. The third case, the right coronary, was not that very easy because of the guide support was not very good. Probably if you had used the amplifiers, it would be easier for you.
Yes, sir.
Other thing, if the stent was not pulsing, I think try a little bit more pedalation with a bigger balloon. That would help the actually stent passage much easier. But anyway, you've shown it very nicely, demonstrated the use of a guidezilla. That's usually what I also do whenever I get stuck. It's a very useful maneuver, and everybody should be accustomed with the use of the guidezilla. Thank you very much, Doctor. Thank you very much for your presentation.
Thank you, sir. Now, Dr. Misbaul Ferdous, we are waiting how China deals with retrograde PCI. Dr. Misbaul Ferdous, our fellow colleagues working in the Feng Hospital, Beijing, China, and also Vice President of Asian Cardiac Society. Dr. Misbaul, do you hear me?
Yeah, I can hear you, sir. So
welcome you. It's late night in China. I think it is 3 o'clock or 2 o'clock.
No, so it's like a 12:46, like a near about 1 a.m.
Okay,
midnight.
Okay, thank you, Misbah. You start your talk.
Okay. Bismillah. So Bismillah ar-Rahman ar-Rahim. So my name is Misbaul Ferdous. So I'm working in Fuwai Hospital. It's a national center for the cardiovascular disease and one of the largest heart center in the world. And basically, I'm from Chittagong. I came from Chittagong, then I did my training in NICBD, 1.5 years. Then 2010, I left Bangladesh. Now from 2010 to 2020, I'm in China. I did my master degree and PhD from China. And I did my fellowship from Japan under Ogata Shansei from Tokyo. And now I'm working as a vice president of the Asian Society of the Cardiology. So we have more than 1,500 cardiologists around the world and inside the China. So let's talk about the today's session. And thanks for inviting me today. Special thanks to Mohsin sir, so who invite me and encourage me, and a special thanks to Professor Amol sir. So first time he invited me in Bangladesh when I was in China. So thanks for everything. So actually, today, I want to tell something like I'm a student of the late Professor Abdul Khan Chowdhury sir. And I'm the direct student of the Khondoker sir and Abdul Wadud Chowdhury sir and Salahuddin sir. So those 4 people build up my career. When I was in ICVD, I have a little chance to meet with some great people who encourage us for the field of cardiology, who invite us, who guide us to run our career for the future. Thank you, sir. So actually, this is my career build-up. So where I get my training from NICVD, University of Alabama Hospital under Naveen Sinanda sir. And I did my 6 months training from Apollo Hospital, New Delhi, India. And I did my complex PCI training in Cathay General Hospital from Taiwan, People Republic of China, and my fellowship from Agio Central Hospital, Tokyo, Japan. So let's talk about the retrograde PCI in LAD CTO. So 5 years, 6 years before, actually CTO is like one kind of dark era in the whole over the world. So only the Japanese CTO expert are the very famous in the whole over the world. Still, they are best in the whole over the world. So that is the reason actually I choose my fellowship training from Japan. One of my boss, his name is Ogata Shansei. So most of the time he told me, Ovik, if you want to do the CTU PCI, the most important is true feelings with the wire in your hand. So you have to very clear idea what you are doing, not the fluoroscopy. Fluoroscopy is only you can see everything in your hand. So he is using very sophisticated one kind of hand gloves. I never see in the other country that kind of hand gloves. These are the very special hand gloves. They made maybe only in Japan, not other country. I travel more than 12 country. I never see this kind of hand gloves. So the boss told me every time, Avik, my nickname is Avik. They told me in English name is Avik. So if you want to do puncture, you can have some feelings. Once your wire some loop, or you do the false loop, or you enter to the false, or you enter the true lumen, every single feelings, first you have to understand. Then you can do the Cto Pci. So 6 months, he gave me many idea, true feelings, how the wire manipulation, because it's still, no matter what kind of technology come, still the wire manipulation is the key success for the doing Cto Pci. No matter what kind of like a expensive product, even I use ADR, if very expensive, but to be honestly speaking, still the wire manipulation is the key success for the Cto Pci. So let's talk about the Cto Pci, about the retrograde. Actually, I have only 15 minutes time. So Mohsin sir told me within 15 minutes I have to finish. So actually everyone know, like a conventional coronary angiography detection only rate is 10 to 30%. So less than 10% of those patients receive interventional therapy. The success rate of the Cto interventional therapy for a long period of time is less than 70% before, like 10 years before. But advanced technology came, a special implementation of the reverse strategies, and the many good doctors in the world, many good technology. Now the success rate is more than 90%. So Cto actually of severe tertiary calcification or bifurcation is still a challenge for the intervention field. So what I can say now, to be honestly speaking, Cto actually not the dark part. Many country, many big expert, many young doctors, many expert in the world, they are doing Cto very confidently, and patient get very big benefit. So 5 years before, 3 years before, I started one kind of trial by the Cto. Like many people are talking, what is the advantage of the Cto Pci? Because people think after the open the only the coronary artery after the Cto Pci, what is the actual outcome? Really, people can get benefit. People have the longevity of their life. So we start like a more than 1,000 patient. We already finished with the 5 years clinical outcome. It's 3 years gone. So another 2 years later, we will publish one paper like a Cto Pci with the 5 years clinical outcome. So everyone know actually the algorithm how to do. So I think we can escape this. So Cto Pci, the algorithm is very clear for everyone. So I think every young doctors know this. So in the Cto Pci, either wire escalation by the integrated retrograde PCI, or ADR technique, or retrograde dissection reentry. This is the actually 4 key part of the Cto Pci. So this is the most troublesome issue, like for the Cto Pci. Many things: guiding catheter, integrate guiding catheter, retrograde guiding catheter, micro catheter, many things inside the one coronary artery. So that is the reason actually this is the many trouble. So we get many lesson every single mistake. Last 5 to 6 years, I have many mistakes. So sometimes we cross the Cto lesion after the Cto lesion. So we just cross, but luckily or unluckily, the wire come out from the guiding catheter. So many mistakes we did. So that is the reason actually Cto Pci need patience, step-by-step procedure, like a step-by-step confidence level can be grow up. So if the young doctors can do the Cto under the any professor guidance, like 100 case or 200 case, I think after the 200 case, young fellow can do the Cto Pci alone. So that is actually my case summary, 75 years old male. So he have a effort chest pain for 6 years. So very exacerbate for the last 4 months. Angiography showed negative dilation, like LAD Cto, RCA like a 90%, mid LCX 90%, and a stenting in RCA and LCX was done in 2014. So risk factor have a hypertension, dyslipidemia, excess smoker. So no previous MI, heart failure, CABG or ECG, chest X-ray echo, and everything is normal condition. So let's talk about the angiographic view, what we can see. So to be honestly speaking, every day we have like a 5 to 6 case, like we are the 6 team member. So every day we have to do minimum 25 to 27 PCI. So once we see this kind of view in my turn, we are very shocked and we feel today is the most bad luck. So after we see like for the young doctors is very scary, then we do the another view. So we are not very clear, then we change our plan to the dual injection. So it's a little bit more clear picture here. And at least we can get idea. So what I can do and what is the safe time for me. And we have many patients, so we cannot do one case for the 2 hours, 3 hours or 4 hours. So we have to decide actually what we need to do. So after we see this kind of issue, like we just go to the directly to retrograde Cto Pci. Okay. So this is actually 6 French EVA catheter in anti-guide approach, and retrograde approach we use the allo catheter, and we use the Corsair BMW, and luckily we finish everything the Cto Pci within 1.5 hours. So luckily it's done. It's almost near to the crossing the lesion. So in my mistake, last 5 years, when we cross the lesion, like we are very lucky, very excited, very happy, then we did mistake. So I have a many more than like a 20 to 30 case after crossing the lesion, then luckily or unluckily the wire come out from the real lesion. So I get my lesson like after we cross the lesion, we never be excited. So after excitement, we did many wrong steps. So this is my very good lesson, and I want to share my feelings to my young people. After the crossing lesion, no need to be excited for the until they come out the real stenting for the Cto Pci. Here actually we use the Gaia 2, but I think I don't know like in Bangladesh you use or not. Like in the Japan actually we use Gaia Nexus as well, but in China, we never use the Gaia Nexus until we have this kind of Gaia 1, Gaia 2. So we prefer Gaia 2. And here, actually, it's entered to the anti-guide guiding catheter. It's very smoothly enter, and it not took long time. It's very clear vision, very clear picture, very clear marking. We are entering to the right part, not the false lumen. So slowly coming down and up. So I think it's very clear way we enter to the anti-guide guiding catheter. Then we are lucky, so we do the pre-dilatation and stenting. I think we are almost done. Then is the final shot is very good, and everyone is very happy after this. So I think that's all for the retrograde PCI. So now we can talk about some other part. So like with the development of the technology, we know like a retrograde Cto Pci increasing, and the overall success rate also increasing after the retrograde PCI come to the many doctors now using the retrograde PCI. But there is some issue like we want to talk about the puncture site. So when we do the Cto Pci, then we have to think about the not only the stenting. After the stenting also, we have many complications. So now we need to think about how we can minimize, how can reduce the complication. So access site complication is very high in the femoral side. Radial side is the less than 14. It's like one of the very good study. But last 2 years, we start something new strategy for the Cto Pci. At least 40 to 50% case, we do the single puncture. Once we fail to do the single puncture, then we start the second puncture. But it can reduce the cost, it can reduce the patient pain, it can reduce the many complications. So at least we can say very confidently, so in our center, more than 40% Cto Pci, we do the single puncture, not the dual puncture. But many countries like Japan, Australia, Canada, USA, many doctors, they from the beginning, they start the dual puncture. But I think we are waiting for some good paper coming out. We already finished the writing, like a single puncture Cto Pci is beneficial in which part, like if some Cto Pci for the proximal cap only we can puncture and we start a small lesion, a small Cto lesion, not the long lesion, then we can do the single, like a single puncture. But if the Cto lesion is distally, then we need to do the dual puncture. But it's still, first we do the single puncture. If nothing can be happen, we don't succeed, then we do the dual puncture. This is the new idea actually we are following from our center. So we strongly believe like no more CTO in the world. So 5 years, 10 years before, CTO means we have to do the CABG. But now we can at least say, no, at least we can try. So if we cannot succeed, then the patient we can send to the CABG. So another one good news I want to share with you, like just yesterday we finished, we start Euro Middle East Asia focused clinical survey. So the ESC president for the working group, myocardial and pericardial disease, Anthony Pantagis, and Fuwai Hospital, me and my boss, Professor Yongjian Wu, we start like one kind of clinical survey for the pericardial and myocardial disease. We feel these two disease most neglected part of the cardiology. Many center just overlook this kind of disease. That is the reason we start collaboration with the 22 National Heart Center, 187 cardiac center, 500 top cardiologists and top cardiac surgeon join in this survey. So I request all of you from Bangladesh can join with our survey, and when we publish our paper, so we can put all the doctor's name and center at the end of the publication. So that's all. Thank you. Thank you, sir.
Thank you, Dr. Misbah. You share your experience, China experience with Bangladeshi people. I think our young fellow will benefit your lecture. Dr. Misbah, you choose the epicardial or septal collaterals during retrograde PCI. Most important thing, choosing the septal or retrograde septal collaterals or epicardial collaterals for the
epicardial. Retrograde epicardial.
But it is sometimes more dangerous because chance of perforation or not closing the.
Oh, actually, when we are doing the PCI, so behind us, our boss every time stand. So that time boss said, follow this. So I'm behind you. So we just follow his advice. So I don't know, perforation, and it never happened with me, but I think we are confident regarding this. And most of the time boss follow this idea, this technology. So we follow our boss idea.
Okay, thank you, Dr. Misbah. Dr. Abdul Jamil, Dr. Abdul Jamil, do you hear me?
You. Yes.
Jamil bhai, yes, sir. Yeah.
Thank you for presenting nice talk and a good case. You are lucky to cross that tortuous epicardial collateral, and in this case, that is the only good collateral for crossing doing the retrograde. But the danger is if it perforates. That's a problem. And another thing is retrograde balloon crossing that tortuous site is sometimes makes difficult, and that might cause rupture of the collateral and pericardial temperament. For the beginner, it would be better to choose a septal collateral. That is safer if it perforates or ruptures. The hematoma is confined within the septum and it does not cause any hemodynamic alteration, and ultimately it gets absorbed. And for the talk of Asaduzzaman, he presented 3 nice cases. I want to mention just a few things about for the beginner. Start with anti-gauge, and in earlier days we used to, when we didn't have microcatheter, we used to go with balloon support. And if you take a balloon, it is better to take a double marker one. Otherwise, sometimes if it is single one, the distal end is not discernible always, and sometimes it might cause damage to the Cto cap in the external way and might cause perforation. And another thing is now microcatheter is available, and it increased the success rate more than 80% in integrate Cto. So one should try with microcatheter first, and I choose floppy catheter when I use microcatheter to cross lesion. If I fail, then I go for higher options. I do use Miracle sometimes. Earlier, that was the CTO wire available in Bangladesh. Now a lot of wires are available. Fielder XT, and then Gaia. And so, and Asahi, probably the Japanese company, Asahi has provided all this type of CTO wires and made the CTO more easier. And even the thin balloons made by Terumo also increase the success of CTO. Thank you very much.
Thank you, Professor Khaled bhai.
Thank you.
My teacher, my direct teacher. Yes, sir.
Yeah.
Thank you, Dr. Mohsin, for giving me the opportunity to comment here. Dr. Misbah and Dr. Asaduzzaman, both they have presented their case very nicely. And what we tell about Dr. Asaduzzaman, he narrated cases which all constraint and limitation, how the cases can be done very nicely. These are the examples of doing the cases, because we have a lot of limitations, constraint, both in economic ground as well as on technical aspects. We are not getting all the hardwares at the moment, final one. So with all this constraint, the Asaduzzaman has nicely performed in all the cases. But about the last cases, I have a comment that without using the guide, he can use a larger size balloon or repeated balloon dilatation, and he could negotiate the stand at the dilution. Probably that was a very good approach for him. Without going directly introducing the guide, he could use the larger size balloon, repeated balloon dilatation, and then it will pass the stand at the dilution. And regarding the second case, what he comments that the implantation of the proximal stand can clear out the distal pathway and distal landing zone. Sometimes it may even create catastrophe. So this not should be a very much clean-cut comment on everywhere. Sometimes an implantation of this stand can produce another catastrophe. So you don't know the path, where is the end of the path. Because it is not only the vasospasm in the distal low pressure system, whether sometimes a thrombus distal to the proximal cap sometimes may produce slow flow, no flow. So that can create the problem. So in those situations, probably you have adopted to use intracoronary P2B3 inhibitors, intracoronary nitrates, probably have used, but repeated balloon dilatation can also help. So that is the one point, that proximal implantation of the stent sometimes may even invite some crisis. About the Dr. Misbah, he was in this connection. I want to memorize Professor Abdul Chowdhury sir, because Dr. Misbah and Dr. Asaduzzaman both are very much linked with the late Professor H.K. Chowdhury, because when I was assistant professor of Professor Abdul Khan Chowdhury sir, I see Dr. Asaduzzaman first time in his office or in his room, who was coming repeatedly with his thesis works, because the Professor Abdul Khan Chowdhury sir was Sir Salimullah Medical College, and Asaduzzaman was his student, and probably he was doing the his thesis was under the guidance of Professor H.K. Chowdhury. So I saw him with very intimate connection with Professor H.K. Chowdhury. And at the same time, I can remember a very hardworking, very sincere man, Dr. Misbah, was very much humble, who knows the etiquette, how to deal with his professor, how to talk with seniors, and how to manage everything. He was very sincere and hardworking. I can recollect the memories that when the Professor H.K. Chowdhury used to give the round in the evening, 3, 4, even 6, or even sometimes 8 or 9 p.m., he was always with me. And some bodies, sometimes I found some bodies and sometimes I found no bodies. But Dr. Misbah was always with me. He was very much hardworking. He managed the recommendation from Professor Sufia Rahman, Professor Nazrul Islam, or even from Professor Fuwai. For many purposes, use the forwarding as well as recommendation made by every professor working in ICB. So it's his studied and it's his credential. He will have many things with his credential, and which I know that when he left Bangladesh, he hard works there. He spent a lot of time in China, and that he got his training in echocardiography, interventional cardiology, nicely, and he is now working in the China very sincerely, very honestly, with a very expert team there. I was very delighted to come to know that he's doing Davi there, and he's doing a private hospital in the Beijing, where all the interventional works will be there, including the Davi. So, congratulations, Dr. Misbah. Lastly, I want to ask Dr. Misbah that what are the situations where you, from the very beginning, choose the retrograde approach? Because in our country, we are not very expert. A few centers and a few operators like to do the retrograde approach CTO. But what are the situations where you, from the very beginning, choose the retrograde approach rather than
So actually, most of the patient, before we do the Cto Pci, we have the very clear picture of the Cto angio. So if the Ct angio, we can feel the very tortuous, very not zigzag case. So directly, our boss never used the try for the proximal cover integrated approach to do the Cto Pci. So our lesion, because we have many patients, so we can very confident that retrograde PCI we can succeed. Then we start the retrograde PCI, because one day, one Cathlab, 25 patient, it's a terrible. We have only 1 hour, 45 minutes or half an hour for the one case, for one patient. So we don't have many theses which we can choose many wire. You can see for the Cto Pci, we only use no more than 2 to 3 wire. But in other country, when I was in fellow in the Japan, I am very sure in Japan they can use most of the Cto Pci minimum wire 6 to 8 in my 8 months training. So this is the one case so that is the reason actually from the straightforward we do the retrograde Cto Pci, and in my view I can say I get the more success in retrograde PCI, because I have a many way I can choose. If not one some trouble, then I can choose the another way. So I feel very comfortable zone for the retrograde PCI. But integrate PCI, if one time we can succeed, if we can cross the proximal cap, or we can open the proximal cap puncture, then it's okay. But in our training, we only can try 15 to 20 minutes for the integrated approach. Then we just shift to the retrograde approach. So that is actually our training base in this way. So that is the reason actually we do the retrograde PCI very confidently.
Dr. Mehta, I like to ask the one question. What is the situation in your center, including China, before approach to the Cto Pci, whether it is antigen or retrograde? Imaging how much percentage, how much cases, how much percentage of patient use the imaging system, IVAS, OCT, and how much percent you can use the viability test of different type of spec, PET, other than CT.
So actually, IVAS, we are using like a no more than 30 to 35% to 40% case. Actually, the main reason, actually, we need to do the more and more IVAS to understand, to clear the idea. But the reality is when the patient load is very high and we have a thinking today, I need to finish minimum 25 case within from 8 to mid 10 p.m. So we can choose maybe no more than 5 to 6 patients for the IVAS, because IVAS need take time. People come, go, IVAS machine come, so it takes a lot of time. So I think in our center, we don't use the more than 30 to 40% case for the Cto Pci, especially for the IVAS guided Cto Pci. But only we are using the IVAS guided Cto Pci because some of the expert in our center, they do the proximal cap puncture by the IVAS guided PCI. So that time they are using more and more IVAS guided PCI. But I think in our center, we are doing more and more like a wire acceleration is good. And more like every April every year, we have the CTO week. In 1 week, we do the CTO minimum like a 70 case. We collect 70 case for the 1 week. So every year, I think 25 April to 29 April, oh no, sorry, May 1st, 7 days.
About viability test, about viability test.
Sir, viability test, less.
Thank you.
Mohsin, can I add one thing more?
Yes.
One thing that regarding the use of Guidezilla, what Asaduzzaman used and became successful, many centers do not have this Guidezilla. And in that case, for a tortuous vessel, one technique I do apply, that is keeping the long stent. Usually this difficulty comes with the long stent passing through a tortuous vessel. So I put a gentle traction on the stent, and with each beat of heart, it gradually progresses, and often I succeed to cross the tortuous vessel.
Traction on the wire, not the stent.
Thank you. We have a few cardiologists here. Our proud young cardiologists, Dr. Aisha Patel, Dr. Anisul Lawal, and Dr. Shubhra Chakraborty. Dr. Anisul Lawal is a young cardiologist, but doing very well in Chittagong. I am proud of you, Dr. Anisul Lawal. Dr. Anisul Lawal, do you have any question?
Thank you, Mohsin bhai. It's very nice to hear two lecture, and one from Chittagong is now doing very well in China. Congratulations, Mesba. We do some CTO in Chittagong, but we choosy to which cases we can handle because we have lack of all the wares and the hardwares. So we choose those cases not very tortuous. We use the JCTO score and not very calcified, not very long lesion. We tried, and we usually go with the double puncture, and we see the contralateral to navigate, and we start with the filter XT, and then we escalate. And we don't have much of choice. Actually, we have up to miracle. We don't have Gaia even right now. So, but we have done successfully few cases. I mean, in last couple of months, we have done like 5 or 6 cases successfully. So it's possible. We need patience, and we need the support of the hardware. I think that could be. And if we don't try, how can we can experience? Because we cannot send all the patients to the higher center. So we talk with the patients that we will try, and up to a certain limit, then we give up. Then we send them to the higher centers.
Thank
in
you,
that
Anis.
will do.
Misbah, can I ask you a question?
Dr. Aisha Kadir, Dr. Aisha, do you hear me?
Yes, yes, sir. Yes.
Yeah, Dr. Aisha. She also doing well. Dr. Aisha?
Yes, so,
Yes.
so I don't do CTOs, but I have the opportunity to assist a lot of CTOs with Saidus sir. And I have a question to Dr. Misbah. Actually, it was very interesting what you said about single puncture in and the upcoming paper, because one, that is something we also, like Saidus also does, and one of the criticisms we have heard in foreign panels and overseas is that you have to do dual injection every time. So which instances you only go for a single puncture, and is it only in cases where you attempt antegrade? Because obviously for retrograde, you have to do a dual puncture.
Actually,
Can you elaborate on your single puncture strategy, please?
Actually, thanks, Dr. Aisha. We get the criticism even from our center. We don't know about the other country or other world, but we strongly believe what we are doing, this is safe for the patient, and we strongly believe like criticism makes us more perfect for the future journey. To be honestly speaking, like when 2 years before we start this kind of issue, like a single puncture, then we start the dual puncture. But I think in this way, we can save people pain, patient money, complication less, because every case we don't need the dual puncture. But actually, I think it's still ongoing. We have a many inclusion criteria. So I think please wait few more days. I can tell you more. But now actually I can say which lesion is the small lesion, not the big lesion, or like when we can cross the proximal cap lesion, it's not a distal lesion. So straightly we no need to do the dual injection. So until everything is okay, CTO lesion open, and we do the IVAS and we see that everything is clear, then we no need to do the more and more complicated patient complication regarding the dual injection, dual puncture, dual guiding catheter. So I think still we are doing very good. No more than, I think 45% case we are doing the single puncture. It's still now is good. Let's see for the future. So I think we are almost done gathering the data. It's a very big data. So hope for the best. So within this year, I think we are confident we can publish very good journal in the very good journal paper.
Actually, if
fellows,
there is a good ipsilateral collateral and that can show the distal segment, you need not to go for dual puncture and dual injection.
That's simple.
But for the fellows, for the young cardiologists, you should use the practice for dual injection because it is more confident about the success of Cto Pci, and also use the microcatheter from the young fellows.
If distal segment is not seen by ipsilateral injection.
Yes. But for experienced center like Fuang Center to Misbah, they are trying to do the single injection. But for the fellows, you should practice. It takes more time for dual injection, but you should practice from the beginning. You use the dual injection.
Sir, we did the dual injection more than still we are doing. So actually what we do, like we start our career with the dual injection. We need to know everything, very details, very clear idea.
Yes.
Now we are thinking about the step-by-step, how we can reduce the pain, how can reduce the cost effective for the patient. But I think for the young fellow, they must start with the dual injection, at least have a very clear idea. When they have the very clear idea, they are confident to do something. So that's the most important key from you, sir.
Yes. Dr. Shubhra.
Mohsin.
Yeah. Sadir bhai, apni last statement. You're the boss. You're the boss. You have the last comment from you.
Okay, sir. Thank you, sir. Thank you for giving me the opportunity. Yes, sir.
You couldn't give question comments. Yeah.
Okay, sir. My question has already been answered. It has been asked by, I have also seen some cases, and mostly in our center, single puncture is done. And I was when I attended some international seminars and conferences, they also were very much prejudiced about the dual puncture. Another question I want to ask Dr. Misbah about the viability test. If on which basis if they are doing viability test less, then on which basis they are selecting the patients, which CTO should be opened or which should not be? Thank you, sir.
Okay. So there is some confusion about the CTO. Like before, many data, many trial depends on the viability test. Some clinical trial regarding the ejection fraction, like after the Cto Pci, how the ejection fraction is increased or not. So we have a little bit different ideology regarding the Cto Pci. So we are very confident about the two-way. Why we are doing the Cto Pci? Not only for the ejection fraction increasing, we have a more than 35 questionnaires for our patient. He can walk, he can round, how many times he feels scared in the night after the Cto Pci or before the Cto Pci, how he feel pain. So we are thinking about how the Cto Pci can improve the lifestyle. Not only the because many trial they talk about the ejection fraction and viability as ejection fraction, but I think we almost done more than 1,000 cases regarding the 5 years clinical outcome. So we feel now we talk about the Cto Pci, not only the real thinking like ejection fraction, viability test, but I feel after the Cto Pci, many people have the great lifestyle. So how long they survive with the confidence, with the less fear, pain for the heart attack, or some good lifestyle. So I think in this way, that is the reason we are opening more and more CTO these days. Thank you.
Thank you.
Dr. Arif, do you hear me? Dr. Arif, do you hear? I think Dr. Arif. Now wrapping up the session by Professor Saidur Rahman Khan for tips and tricks. This is our last session of Cto Pci. Dr. Saidur Rahman.
Yeah, Dr. Misbah, you just 11 years. I was 7 years in Europe, and after coming back, my mom even says that you look like you're talking like a European, not like a Bengali. And yeah, for 11 like years Chinese. Means you look like a Chinese and you are talking like a Chinese, and boss is always right. And these sort of things, that discipline in China is very much important, and that's why they're developing. And at the same time, which I feel that we have actually we can do a lot of work with China because of the same reason, because of like you have a time consumption is very much important for you, for your country. At the same time, also the resource tailoring approach for any sort of PCI, and that is also happening in our country too. So mutual studies may happen here. Like my 25% CTO cases, I don't do dual puncture. I don't need to do, because now I feel that this one doesn't need a dual puncture. But for fellows, no. But for fellows, it should be done. And if you go for a bi-radial approach, the complication rate is less, very much less. So you don't need to think of that one. Or pain, yeah, one puncture or two puncture, just doubling the pain or just almost the same. The second thing is for the fellows nowadays, I'm telling that everybody is telling this thing. There's why on earth we are always talking about the viability test. Because this thing is not that much nowadays in other registries, our cities. There, it is not there. It's not there because to do the CTO is actually to alleviate the patient's comfort, to decrease the angina, and also to prevent double jeopardy, which I'm telling again and again, that you have a CTO RCA and then you have an LAD, which is 50% stenosis. You don't need to stent it. But if you don't do the CTO RCA now, and after a few days, or after a few months, or whenever the God will permit, then if he comes with a total with an LAD occlusion with an anterior MI, the patient will have an anterior and inferior MI at that time, at the same time. So he's in double jeopardy, like in Explore CTO trial, it has been told. So these are the things. So viability is not even, has been downgraded in the guidelines nowadays. This is one thing. And another thing, and everybody in the CTO operator and everywhere, just everybody tells that that microcatheter. Microcatheter, I'm telling, because Dr. Anis is in Chittagong, started doing CTO, and in different hospitals in periphery also, to arrange a microcatheter is around 30,000 taka. And when you will reuse a microcatheter, that lubricity of the microcatheter is gone. Inside lumen is too much different. It has a torque somewhere, because when you are washing it, some torque is there. So when you want to take the microcatheter out from the wear, it is not possible by the indeflator, which usually we do, because at that time microcatheter is coming even 20 atmosphere, you are with an indeflator. So then you need a dock extension in that case. Dock extension is very, very few in our country. I have just only one. I'm using it for the last 4 years. So just very carefully, I'm telling the companies, but they are not taking it. So microcatheter is, just to tell the microcatheter is not always important, because to tell it, but it's not going to happen. So I'm not going to go for CTO. I don't have microcatheter, not like that, because I have already my one paper with Aisha has been accepted in the Euro PCR, and you can hear that one, an abstract with a tailoring approach CTO. That means with a 1.255 or 1.26 balloon support. That with that balloon support, easily my 80% PCI, CTO PCI, I am doing with that support. I know that some of the CTO operators will oppose me vehemently that how you're doing that one, or why you will do that one. You can't exchange one wire to another wire upscalated. If the CTO is not too much distally, if the CTO is not that too much distally, then you don't need a microcatheter, because again, another wire you can take easily up to the proximal cap. But if the CTO is too much distally, then every time another wire to take another wire up to distal part is really cumbersome. So then it's better to take a microcatheter, and it's very much easy. Otherwise, 1.255 balloon, it has a long delivery system. That one acts like a microcatheter. I'm telling that one again and again, and because I'm doing it, and I have done so far like 1,000 CTO, and I am 70% of my CTOs with 1.255 balloon support, and I have been successful with that one. So you can start with that way, fellow, but of course microcatheter helps. But now after doing that 70%, I feel better with the 1.255 support, my tactilism, which Dr. Mesva has told. I tell to my fellows, and in all my lectures, and in my lecture also I have told, in CTO, you don't have the visual sense, the most important sense of a human species. You don't have any visual sense. You have only one sense, that is a tactile sense. So it's better to have a very good tactile response. It is very, very much important to be a CTO operator. If you are not that much, then don't try to be a CTO operator, because that one is the best thing for do. And for by that way, any wire escalation, and especially please try to keep Gaia series, because that one is one of the beautiful most wire, I can assure you, I can tell you. And that one is very much helpful for going for a easy CTO success. Thank you. Thank you very much.
Thank you,
Sir,
sir,
we started CTO, say around 2005, I did the first CTO. At that time, microcatheter was a dream for us. When we used to go to Singapore, we used to say they used to use Tornas, microcatheter, these things. And we used to, when we will be able to get those things. Vendors are not bringing it as because people do not buy it. So we started with balloon support, and initially most of the cases were near about 20-30% cases without any support. Usually a microchannel can be integrated and can be crossed easily. But balloon support helps a lot. It increases its success rate more than 60-70%. Microcatheter has increased in more success. So if one does not have any microcatheter, should not try CTO, that's not correct.
Yes, surely. For the Anis level, for Chittagong, I just think something. As you should have some kept in your cath labs for CTO, some balloon, 1.2 into 6, 1.2 into 5, as Professor Asaduzzaman said. But one thing for the government that we use the microcatheter 4 or 5 times for 5 cases. But what thing you should preserve the microcatheter by yourself, not by the technicians. You reuse the catheter, wash it thoroughly, and put a wire in the microcatheter, preserve it in your box, and then can reuse. And I can easily remove the microcatheter by the infusion device, not blocking, but use the water in the infusion device and use the infusion you can carry out. But one thing, you should preserve the microcatheter by yourself, not by the technicians. And you must use the 1.2 balloon and 1.26 or 1.5 into 6 must in the cath lab for successful CTO. And I thanks everybody. And I think in the midnight, Dr. Misbah at 1 o'clock or at 1:30 in the China. Thank you, Dr. Misbah, being with us. Dr.
Mohsin, he is Chinese. He can work whole night.
Yes, actually, to be honest, when I was a very young fellow with my boss, 2018, morning 8 to midnight 1, we never come back home. We maybe 2, 3, we just came and again go for.
But Dr. Khondoker Asaduzzaman, thank you everybody. Our young fellow doing very well. Dr. Aisha, Dr. Shukro, Dr. Anisul Awal, Dr. Arif, Dr. Moti Rahman, Dr. Tanvir. Lots of young fellow doing very well in the center. I think they are also hardworking. They're doing the 24/7 work in the primary PCI. I think Dr. Misbah, you can contact with them and train them in China or the other parts. I think already you helped them a lot. Thank you, Dr.
Start
Misbah.
doing trials. Dr. Misbah, start doing trials with us.
Yeah, sure,
sir.
Thank you, Beximco Pharma, being with us at the midnight. Now I'm requesting Professor Wadud, sir, please conclude the session with some tips and tricks for the fellows. How do we start the? Last question from the Professor Saidurrahman. Last question, Professor Saidurrahman. Yeah. Why not you start the retrograde PCI in Bangladesh? Why not so much? We are so much long way to go, but why not start the retrograde PCI in Bangladesh? So much.
Retrograde PCI in Bangladesh is you know that this is also especially for the private centers, especially for the not for the government centers. For the private centers, the people are very choosy. People are very choosy and people need success. And when there is no success, rather a complication is there, yes, then it's very much hard to give an answer, especially for a CTO where the other vessels has got no stenosis. Patient was just have some angina, nothing else there. So this is one of the reason I think that some of the operators are very much shaky to take that burden in our mind. But the thing is that what Dr. Misbah was telling us, retrograde PCI is really not that much cumbersome unless knuckling wear or severe calcification is there. If those things are even there, retrograde PCI is easier than an antegrade PCI. Sometimes antegrade PCI will sweat you more than anything, but retrograde PCI can be easily done. But only one question is that if any complication happens, that because you know that is true, that retrograde PCI has much more complication than antegrade wire escalation. That's true. So whenever I will make a complication with antegrade wire escalation, I have an answer that this may happen, and this is like 4%, 5%. But when it is for retrograde approach, the complication rate is more. So why you have done it? The question will be there, why you have tried for it.
Another hurdle is there in the private sector. The appropriate hardware we don't.
No, we can get it, Jamil Bhai. We can get it now. We can get it.
Not in all.
In every center you can get it if you try, because like IVL is coming, and you know that in every center you will get it. You can get it because people can pay. People can pay, so we can get it.
I'm asking about the authority. I'm telling you, they don't buy all the hardwares for doing all sorts of pieces.
Give them the smell of money, they will buy.
difficult.
Okay, thank you. Dr. Asaduzzaman, Dr. Asaduzzaman, do you hear me?
Yes, I can hear you
last
clearly.
question, easy
Yes.
for the young fellow, for the easy question for the fellows. For the dual injection, when engagement of the two catheter in the two ostium, what should be more for the young fellows in the pressure curve, also the two catheter in the two ostiums? How they handling this young fellow?
Actually, when you select the two catheters, guiding catheters, one catheter for the successful CTO, that is if in relation in the RC,
mute yourself.
We can choose it's 6 or above size French catheter, but for the injection, that is the contralateral injection, we should consider the undersized catheter, that is 5 French. So 5 French catheter does not obscure the flow to these lesions, and there's no chance of pressure damping and another means. And just after injections, you can keep it away from the ostium. But simultaneously, definitely you should look for the pressure curve, and you should look for the ECG change. Definitely, this is sure. But simultaneously,
do you use the two pressure curve, pressure machine? Do you use the two pressure wave?
Two pressure wave, yes.
Yes, Mohsin, can I add something here? Because it was in my lecture. It was in my lecture that dual injection, because this is very important. The first thing is that, again, I'm telling to the fellows, donor first, then the receiver. Contrast should be given, the donor first, then the receiver, not simultaneously. A bit later. This is the first thing. Second thing is that don't take a XB guide catheter for a donor vessel.
Right, exactly.
You don't need it because XB guide catheter will be there. And third thing is that what I usually do, I don't know what people do the same thing or not. I'm very much afraid because I don't like two catheters in the two ostium all the time. I usually pull the donor catheter a bit away after injection, and again I engage. It's rather better because whenever you're doing the CTO and you're moving here and there, or the scrub is taking one system to another, they may push the catheter.
Nice.
They may push the donor catheter, and the donor catheter, and without your consent, the donor catheter will be so deep, or is going to injure the left main or injure the RCA. So it's better to pull it a little bit and again take another, while taking another issue, you will engage it again. It's better.
Dr. Asad.
Obviously two pressure curve.
Yes, Dr. Asad, last question. For the bi-radial approach, sometimes it is difficult to engage the catheter.
No,
so you comfortable?
I don't feel so.
Comfortable to use the bi-radial approach?
No.
Yes, I do feel comfort with the bi-radial approach.
Actually, left radial, it behaves like transfemoral. It's so easy to engage and manipulate catheter. Only thing, the hand is on the opposite side. You have to be more closer to the.
For yourself is easy, Jamil bhai. Yourself is easy, but the fellows,
But the fellows, Mohsin,
left radial is easier than the right radial. Right radial manipulation is much.
Yes, Sajid
No, Jamil bhai, not that one, not only that one, left, right, not that one. The thing is that which catheter will you engage first? That one is very much important because otherwise sometimes they may wrap up. If it is also possible for femoral, bifemoral, or biradial, whatever it is, it doesn't matter. The matter is that you shouldn't wrap, because sometimes while engaging the second catheter, you will see the first catheter is moving because when you are torquing that one. Especially left radial, when you're using and you have a unusual or anomalous origin of RC or left, in that case, usually what we do, engage the right one first and then the left one.
And another important issue is that when you try to bi-radial approach, actually for the left radial, you should prefer the distal radial approach for the left, and for the right, you can use distal.
Why, Dr. Asad?
As because it is a very comfortable for the patients. No need of that is the supine positions of the hands is very difficult for persistent use of supine position. But if it is in a prone position,
even in radial approach, you don't need a supine position. I usually after just
no. I don't mention the supine position of the patient. The supination of the hand.
I'm telling supine position you don't need. Even after puncturing that one, you can relax the hand and you can make it like straight. You can do that one also. So distal radial, if you tell to the fellows again, then they will be in another trouble, because so those who are not practicing distal radial yet, that will be another problem. So don't. It's better to go with the radial bi-radial approach.
Thank you, sir. Thank you, everybody. Professor Wadud, sir, please conclude the session with some remarks for the fellows.
Before conclusions, I'd like to add one point. Actually, I am very much delighted to see Dr. Mesbah in this webinar, as because I have the few experience in working in the Fuwai hospitals in 2017 as a fellowships. It was a very amazing experience. Actually, I have never seen these types of hospital in the world. At 12 or 8 cath labs in the
now we have a 17 cath lab. 17.
Oh, I have seen 12 cath labs in the same floor. It was a very amazing experience. Thank you very much.
4 hybrid cath lab, 4 hybrid for the TAVI.
It is the biggest center in the world.
Yeah.
Yeah. What is that? Please comment, sir.
I think the young fellows have learned a lot, particularly from the discussion as well. And as we have mentioned, and Saidur later on summed it up nicely, you have to have a plan. You have to think about whether you are going for single puncture or dual puncture. If you're going for dual puncture, then engage the right guide catheter on the left guide catheter. Which one you will do? Decide about that first. When you are taking the injection, see that you are pushing the donor dye first, because that will be going through a long way across the collaterals into the, then you put silver dye. Simple thing, but very useful points that help you. Again, look at the blood pressure curve, because you are putting 2 catheters into ostia. You have to be careful. Choose the guide catheters very selectively. Think about the wear. And for a cost-effective way, in our country, when everybody do not have the microcatheter, or we are using the microcatheter, which actually reduces its efficiency very much, you can go for, as Saidur is saying, actually, all of us are practicing that. Use a 1.25 or 1.5 balloon support, and your wear will be penetrating very hard CTO indeed, with perseverance. And Saidur has been using his fingers. And as Misbah has summed it up, you have to have the feeling. Where are you going? Are you going through the calcified lesion? If you have the feeling in hand, you will find that it's like walking on pebbles when you are going through a calcified lesion. You have the feeling like that. And that feeling, whether you are going in the right way, whether you are going in the troublesome way, use orthogonal views. All those things, all those paying attention to detail, that is important. Microcatheter helps. Different types of wire helps. But what helps most is your mind, whether it is prepared or not, whether your patience is enough or not, whether you have looked into the other things. You are doing a CTO, but damaging the kidney of the patient, not paying attention to that his creatinine was 1.7, 1.5. That's not good. You have to treat the whole patient. And all those things should come with your knowledge, patience, perseverance, and practice. As somebody was saying, if I do not try, how can I have the practice? You have to try. Start with a very small one, very apparently small lesion, discrete lesion, CTO, and then go ahead. You can really do much better than our generation. Our predecessors, they have led us to this level. And we are trying to lead you to a much higher level, much better than us. I hope we will succeed. Thank you, everybody, the presenters, the faculty, the audience, and foremost, and never forget, the Beximco Pharma, who has helped us continue this educational process for a long, long time. And in the last, I would thank personally Dr. Mohsin Ahmed. He is the backbone. He's the spine of this whole program. And he has shown, he is like a city operator in this educational field. And he has succeeded very nicely. And we are seeing the educational flow going on very nicely, TB3 flow. Misbah is joining.
Very nice example.
Anis is joining from Chittagong. And I see somebody joining from Sylhet. So this is nice. And I hope our together sharing knowledge will continue. Thank you, everybody, and good night.
Thank you, sir. Assalamu alaikum, sir. Thank you, sir.
Assalamu alaikum.